Okay, that's kind of what we're going to focus on in first semester. You'll get your feeding about decompressing the stomach. Why would we be doing that? What type of patients would need that? Okay, what happens in your stomach? What takes place? Digestion. So if your stomach, if you ever get in a situation where you can't digest your food, what happens to your food and your liquids? It just sits there. And if it sits there long enough, it's going to obstruct, okay? And it's also can grow bacteria. Okay, so we want digestion to take place, and when it doesn't, it causes us problems. So y'all are just coming off the concepts of mobility, immobility, and elimination. So does somebody being immobile put them at increased risk for GI problems?
Yes.
Yes, it does. What about patients who go to surgery? Okay, what happens in surgery? Like, what do they give them in surgery that could affect their GI system?
Anesthesia.
Huh?
Anesthesia.
Okay, medicines to slow things down, right? So, and put things to sleep, not just, our body, not like not making us just sleep, for decompression and for actual removal of gastric contents, bowel. It can sit there. So if we don't remove it with a tube, then eventually what can the patients begin to do? Vomit, and they'll vomit up bowel and stuff. Okay, so when you put down a nasogastric tube, number one, is it a sterile procedure or a clean procedure? It's a clean procedure. Do you have to have an order for it, or is it considered a nurse-initiated intervention? You have to have an order, because if you do it incorrectly, you can cause problems. What's the worst problem that can happen when you put down a nasogastric tube?
It can go in the stomach.
It can go in the lungs instead of the stomach. Okay, and when things go in the lungs, especially if you're putting it down for feeding purposes, you can cause them to aspirate, and then that can turn into aspiration pneumonia, and that just leads like down a rabbit hole to death. Okay, so you want to be very, very careful. All right, so anytime you do a procedure on somebody, you need to, number one, wash your hands. Okay, and then you do proper patient identification. How do we properly identify patients in the hospital?
Identify with the.
So y'all, you're not wrong when you say that. Yes, name and date of birth, but you're asking them their name and date of birth, and you're comparing it to the armband. Like, I would not just walk in and say, "Hey, Miss Jones, I'm gonna put in an NG tube." Okay, I'm gonna walk in and I'm gonna say, "Good morning. My name is Wendy. I'm going to put in a nasogastric tube. And explain the procedure. Tell me your name." And she would say, "Tina Jones." And as she's saying that, I'm looking and verifying. Okay, that's the purpose of doing that correctly. You gotta have an order for this. Now, the order, they may tell you what type of tube, they may not. There's different types of nasogastric tubes, different sizes. So, like, this is for that's for a baby. You wouldn't want to put this down an adult patient, right? So the provider may not, they're going to think that you've got some knowledge coming in, okay? So a regular nasogastric tube may be called a Salem sump. It depends on the packaging, but they're kind of big. Like, they're considered large bore tubes. You can have smaller bore feeding tubes, and those are called KO-fed tubes. They're T90. Okay, so just pay attention to whatever equipment that you are gathering. So you see this tube has numbers on it. Mine still has some tape on it from the other groups. So besides the tube, what other supplies do you need when you're putting down a nasogastric tube?
Syringe, the little acid
Gloves, definitely. Okay, so we're gonna want some pH strips. Okay, what else?
That blue tag.
Tape. What else?
cup.
Why a cup of water?
To swallow.
I want y'all to think about that for just a second. So, do we put nasogastric tubes down people who are awake and alert?
Yeah.
Yes.
Mhm.
Do you put them down unconscious people?
Yes.
Yes. Do you put them down confused people?
Yes.
Yes. Do you have to kind of do things a little bit different depending on what type of patients you're putting them down with? Because do you need a cup of water for an unconscious patient?
No.
Okay? Can people follow your directions if they are confused and disoriented?
No.
Probably not very well. So some people may be a cup of water and ice, some people may not. Also think about why you're putting the tube down to begin with. Because if you have somebody that is NPO because their stomach does not work, they do not have peristalsis, and you hand them a cup of water, typically people are thirsty. If they drink a whole cup of water and this is not working, that's going to make their condition worse. So I'm not saying you can't give them some ice chips, but be very limited. Think about why they're having this procedure done in the first place. Okay? So maybe not a cup. It just kind of depends. What else? A tongue. Okay, what's the tongue depressor for?
Pull the tongue back.
To pull the tongue down, because when we're putting the tube down, it can get coiled in the back of the throat, and you'll think you're doing a fantastic job and you're getting it where you need to go, but it's really back here in the throat. So we want to look and see. So with the tongue blade comes a pen light in case you need to get a good visual image. Emesis basin. Anybody in here have a sensitive gag reflex? Okay, what do you think patients do when we put tubes down their nose and into their throat?
Gag.
Okay, so if y'all think if their belly is not working, okay, and they start gagging, what are they going to start doing? They're throwing up. This is ineffective. Okay, get you something you can actually use. Okay, some sort of towel or blue pad just in case that happens. You need a 60 milliliter syringe. Y'all try to get off of calling it 60 cc's. Okay, we don't use cc's anymore as an abbreviation because that can be misinterpreted. If you have an order for something 5 milliliters and you write it in 5 cc's, what can that turn into? Like if you write cc's real fast. 500. So you're taking a 5 milliliter dose into a 500 dose. That's versus somebody's going to live or somebody's going to die. Okay, so you want to be very, very careful. But you do need a 60 milliliter syringe because we're going to have to pull some gastric contents out and test it. Okay, all right, I think that's about it. All right, so we've got our order. We have come in, we have identified the patient, I've identified myself. Is this an uncomfortable or painful procedure? It's definitely uncomfortable, should not be painful. So how do you get people to cooperate with you when you're doing an uncomfortable procedure?
Talk through it.
You talk to them, you explain to them what you're gonna do. Part of putting in a tube to somebody who is awake and alert, you need to establish a means of communication. If they get to coughing and choking and gagging, then you need to probably do what? Stop. Stop where you are, give them a minute to kind of recuperate. You may have to give them some oxygen, and then you start again. So that's what you need to tell your patient. Yes, this is going to be uncomfortable. This is what's going to happen. This is what I'm going to ask of you. Okay? I will do this to the best of my ability and get done and get through it as quick as I can. I need your help in order to make that happen. Okay? You need gloves on. Now, how do I know how far to put this tube?
Nose from the nose, the ear to the xiphoid.
Okay, NEX. Nose, ear, xiphoid process. Okay, that's how you measure it. And then you want to mark it with tape. And this is already marked with tape so you know how far to go down. This tube has numerical markings on it. Some do, some don't. Okay, it just depends on what equipment you have that day. Something else we forgot, we didn't say, we need some lubricant for this tube, okay? So, you wanna have all your supplies together. Now, is this a one person or a two person job? It can be one person if your patient is cooperative, but if they're uncooperative, you're probably gonna need some help holding, or reminding, don't pull that, don't tug that, because if you have somebody confused, when you go to put something in their nose, what's an automatic response?
Swat at it.
To swat at it or swat at you. It's not that they mean to, but, we don't necessarily want to get an order for restraints. They just may need some temporary restraining during the procedure. Because once you get it past the nasopharynx, y'all, it becomes more of an irritant rather than it hurting them. Okay, getting it past, like from here to here, is the most difficult part for your patients. Okay, so what position does the bed need to be in?
High balance.
High bowers, they need to be sitting up, need to have it to a comfortable working height. For me, I always remove their pillow. It just makes things easier. Now, something else, this right here, this little blue, I call it a pigtail. I'm sure it has an official name, but I don't know what it is. This doesn't have to be connected to anything. This just kind of hangs for airflow. So you should not see nasogastric tubes that look like this right here, okay? It's ineffective. You don't have to do that. Nothing is going to come out of here. Now you need a connector for this part, because if you're putting it in for decompression and you leave this open, stuff is going to flow out. We connect these to suction sometimes, or a feeding tube, you know, if that's what they're getting it for. All right. I'm going to go ahead and attach my syringe because I know I'm going to want to pull some fluid out. This just kind of saves me a step. Okay. So I'm going to go ahead and have that attached. I would put my gloves on. I would lubricate 3 to 4, inches. When you go in, how do I know which nair to go to in?
Pick one.
Just anyone? I'm on the right. I'm going to go to the right. What are some things you need to consider though? Everybody do it. Deviated septum. They ever had any nasal trauma, nasal surgery? So y'all do a sniff test. Cover one. Is one side clearer than the other?
Yeah.
Yeah, so if your patient's awake and alert, get them to do that so you don't run into any interference, whatever that interference may be. You know, because you can tell even with your own, one is a little bit better. So you want to use that one.
The better one?
The better one. Yes, the better one. Because if you got one occluded with a bunch of boogers and stuff, you're probably going to meet a lot of resistance when you go in and put this tube in. If you meet a lot of resistance, should you force it in?
No.
No, you shouldn't, because can't you cause some trauma to the nasal mucosa?
Yeah.
Yes. What is a medicine that patients take that puts them at risk for bleeding? Aspirin, blood thinners. So you may have a bleeder on your hands if you go in there and try and force it. So you want to be really, really careful.
But they won't have difficulty breathing out of their worst nostril?
Well, the other one's still working.
Yeah.
And you're not, even when you put this tube in, you're not occluding the whole
Okay.
nair. They should still be able to breathe. What if they have oxygen nasal cannula?
Oh, hey, you put that lubricant on there. Ain't they gonna catch them on fire?
No, no. This is okay lubricant.
Oh, okay.
KY can go on the lips too.
Okay.
That's what that is, KY?
KY jelly.
Water base?
Huh?
That's a water base.
Yes. Somebody went somewhere they were supposed to go with that statement. Leave it alone, sir. Step out if you need to. All right. So when you put this in, so you want to have them flex the head back first, and you put this in their nair, and it's not going to thread on these mannequins, but you want to point it towards the ear, okay? And then when you see it past the nasopharynx, like you want to go in and kind of twist, then you get them to kind of flex forward and bend their chin. Now, this is not going to advance, but when you're advancing on through to your marking, you want to twist and go at 180. So it would kind of look like this right here. Swallow, 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 swallow. Okay, that's if your patient can cooperate with you. So that's where your ice chips come in, and maybe your sips of some water. That can help to facilitate swallowing the tube. If you're not able to advance for whatever reason, you can look and make sure that it's not coiling up in the back of the throat. You shouldn't see it coiling up. You should see the tube, but it should be going straight down. Now, if you get to this point right here and they start like doing all that, where is the tube?
In the lung?
It is in the lungs. So what do?
Take
Pull
it
it back out?
You pull it all the way out.
No, you would stop at the little thingy thing.
Why would you not want to pull it all the way out? Because you're gonna have to put it right back in. What is the worst part, y'all? From here to here, okay? So just pull it back enough to where they stop coughing and stuff. Give them a minute. You may have to let them take some deep breaths. You may have to give them some oxygen if they desat, and then say, okay, you ready? We're gonna start again, okay? And then you start again. Okay, yes.
What was you gonna say about the oxygen if they have oxygen?
So if they have oxygen nasal cannula, you would, while you're putting the tube in, take the ball prong out of that nair and just stick one in the other. But once you get the tube in, okay, they can still have a nasal biprong in there
okay.
too. It's okay. Because you can't just say, I'm gonna take the oxygen out, because if they're on oxygen, they obviously need it. If you're gonna run into some issues, like if they have a really small nair, you may have to swap the oxygen delivery device, and they may have to go on a mask. That just kind of depends on what's going on. Now, once I get it down to where it needs to go, I still want to verify my placement. So should I ever let it go like that? No, because it'll come right back out, and we don't want to go through that again. So I'm going to just kind of temporarily tape it. I know it looks funny on the forehead, y'all, but I just do it to get it out of the way. You can tape it to their little cheek, okay, if you want to. But this is just a temporary fix until I verify my placement. I'm going to take my pH strip. Okay, and I would pull out a little bit of gastric juice, 5 to 10 milliliters, I think is what your book says. Now, you see what I'm doing here? Why am I pinching that? Because I'm fixing to pull this out and put it on there. If I leave this hanging, what's going to happen? It's going to come right back out. That's right. You'll learn. Do it one time and you'll remember, okay? I'm going to check that, and then I'm going to put this back in here, okay? Now, when you're checking pH, what should the pH be? Should it be acidic or basic?
Acidic.
It should be acidic. So if you're looking at a numeric scale, okay, should the number be low or high?
High.
It's low, because low numbers indicate acid, high numbers, because what's normal body pH? Y'all remember that?
7.
Like 7 point. Yeah. So you know if it's 2, they're acidic. If it's 10, they're basic. So that's what you're looking at on the pH scale. So, are you just acidic in the stomach? Meaning, is there anything about this nasogastric tube placement, using the pH strip? Am I 100% sure that I'm in the right place if I get a reading of 3 on here? Or 1?
No.
Why not?
Because you could be like at the tip of
Where could you be?
Either too high
the
or too low.
So they're not coughing or anything, so you're not in the lungs. But where else what does 90% of Mississippians deal with on the daily basis? Reflux. Gastric esophageal reflux disorder. So that's acid where? In your throat. So if you don't have your placement, if you don't have it in the stomach where it's supposed to be, and it's kind of up real high, maybe, in the esophagus or whatever, it could give you a false positive. So if you're putting this in for feeding, do you want to be 98% sure you're in the belly, or 100%? 100, because if you're not 100% sure, when you feed them, they're going to aspirate, and then you're going to be dealing with a whole nother set of problems. Okay, so once I get 100% verification, now I'm going to secure it to the nose like it's supposed to be secured. And y'all, this is not the correct tape. Yes.
So how would you know 100%? Like if it was acidic,
Chest
X-ray.
X-ray.
okay.
Because
Now,
you
you
can
gonna do
see.
that every time you put in one, or just on?
It's going to depend on your agency policy. Now, in your check sheet, it does say you would get X-ray placement. Okay. But you would check with your agency policy. I've never seen anywhere that I've worked that if you were putting one down for feeding, you didn't verify with the X-ray. But if you're putting it down for decompression, like if stuff starts free flowing and coming out, and you verified the pH, you're in the stomach. Okay, but still, y'all, with feeding, I don't want to wonder. I don't want to be 98%. X-ray is going to be your best. Now, when you're ready to secure it to the nose, you get you some, what'd you call that tape, Miss Blunt? Fabric tape? It's like white, silk tape, there you go. But you wanna split it like this right here. Put on their nose, like so. They're split. This tape's not really gonna stick that well, but. So what you don't wanna do, y'all, is you don't wanna occlude the nares with the tape. You don't wanna occlude the nair that the tube is in, and you don't wanna occlude the other nair, okay? Something you wanna pay real close attention to, your markings, okay? Because that goes in your documentation. If I was to document this, I would say nasogastric tube inserted to, you know, it was supposed to be 55 centimeters to right nair, because if Vanessa comes and works behind me, something she's going to assess with her physical assessment is she's going to be looking, if I report off to her, hey, the NG's in the right nose and it's taped and secured at 55, then when she comes in, she should be finding 55. If it's not at 55, if it's at 45, should she be concerned?
Yeah.
Yes. If it's at 65, she should be concerned. So that just kind of becomes an additional part of your assessment. All right.
Would
That's kind of hard to measure then. Yeah.
before you tape it on, are you gonna want to add like extra lubricant around to prevent irritation, or just whatever you?
No, you just, but that does, but you know, y'all are used to with your physical assessment shining that light in their nose and their mouth, checking mucous membranes. You want to be careful because this can get irritated. That's why we usually use some benzo, what is that stuff called?
Tincture of benzoin.
Benzoin. It helps to secure the tape, but it can still come off and come loose, especially if you're having to move them and turn them frequently, or if they're diaphoretic.
Yeah, even if it's even around the tube in their nostril.
Mm-hmm.
Okay.
So you want to make sure if this person is getting them for feedings, they need to stay up at 30 degrees. Okay, y'all know aspiration that's what we are concerned the most about. So if you ever take care of somebody with feedings, continuous feedings, they should never be laid flat. Never, y'all. Even if, you know, you go in and you press hold on their pump, okay, because there's always food sitting in their belly. If it's a continuous feeding, it is continually going on. And when you lay them flat, that means it's going to reflux and go up and go into their lungs. But we lay patients flat a lot to turn them and change them. And people who are on tube feedings have a lot of loose stool. So it's real easy for us to say, I'm just going to put it on hold and then lay them down, but there's still food sitting there. Okay? How would you know if somebody has aspirated?
It would sound like fluid in their lungs.
Their lung sounds will become adventitious, that you will go from hearing clear lung sounds
Mhm.
to
To
extra
muffled.
lung sounds. Could be some coughing. If it's been several days and they have a nasogastric tube for feeding, you may see an elevation in their white blood cell count, a spike in their temp. Their O2 sats that were 95 to 100 could be 91, 92. The point being, you are looking and you are recognizing, okay? And you know, going in there, they've got that tube, they're getting fed, they're at risk for aspiration. I best make sure they don't get it. What am I going to assess? What am I going to look for? What am I going to do to prevent it from happening? Okay? Yeah. All right. So anyway, that's that. Y'all make sure to read about it. There's a skill in your book, skill 42.2, and also a check sheet that's in your student handbook. That's what you'll do your validations from. When you read skills in your book, read the skill, read the rationale. It's not enough to be able to do the skill. You got to know why you're doing it. All right, and Ms. Blunt's next.